Dr. Benilsha from the Department of Anatomy. I have 2+ years of teaching experience involved in 3 ongoing research projects, also a lifetime member of the Society of Clinical Anatomists. So let's get into today's topic, the facial neurovasculature. So at the end of the session, the students should be able to describe the origin, course and the branches of the facial artery, also the formation, course and the tributaries of the facial vein. They should also be able to explain the surgical importance of deep facial vein, extracranial branches of the facial nerve, also the lymphatic drainage of the face. Let's get started. So the first objective here is the facial artery. So the facial artery, it is the chief artery present in the face responsible for the rich vascularization. So it arises from the anterior aspect of the external carotid artery just above the level of the tip of the greater cornea of hyoid bone. The course of the facial artery, we can divide this into 2 parts, the cervical part and the facial part. The cervical part, it extends from the origin of the artery up to the anterior-inferior angle of the masseter muscle. It ascends deep to the submandibular region and it makes a S-shaped bend with the first convexity over the submandibular gland, then with the convexity downwards over the base of the mandible. Next is the facial part. It begins where the facial artery winds around the lower border of the body of a mandible. In the face, artery passes tortuously about 1.25 cm lateral to the angle of the mouth. It ascends along the side of the nose to reach the medial angle of the eye. So throughout the course, the facial artery is tortuous. This tortuosity prevents from overstretching of the walls during the deglutition and the movements of the mandible. Next, branches of the facial artery. So the facial artery, it terminates by anastomosing with the dorsal nasal branch of the ophthalmic artery. The facial artery branches, the cervical part, it gives off ascending palatine artery, tonsillar artery, glandular branches and the submental artery. The facial part, it gives off inferior labial artery, superior labial artery, lateral nasal artery and the muscular branches. Facial vein. So it is formed by the union of supratrochlear and the supraorbital vein into the angular vein at the medial angle of the eye. So if you see the course of the facial vein, it runs downwards behind the facial artery as a facial vein. It crosses the submandibular gland superficially and joins with the anterior division of the retromandibular vein to form the common facial vein. Later, the common facial vein drains into the internal jugular vein. The tributaries of the facial vein are the angular vein, superior labial vein, inferior labial vein, lateral nasal vein and the deep nasal vein. Next, the important topic is the surgical importance of the deep facial vein. So the deep facial vein, it connects the facial vein with the pterygoid venous plexus. Through the emissary vein, the pterygoid venous plexus communicates with the cavernous sinus. The facial vein and its communications are devoid of valves. So infections from the dangerous area of the face spreads in a retrograde direction from the facial vein to the cavernous sinus, leads to meningitis and the cavernous sinus thrombosis. The next topic is the extracranial branches of the facial nerve or the terminal branches of facial nerve. This extracranial branch or the terminal branch of facial nerve, it innervates the muscles of the facial expression through the temporofacial trunk and the cervicofacial trunk. The temporofacial trunk, it gives of a temporal branch and the zygomatic branch. The cervicofacial trunk, it gives of a upper buccal, lower buccal branch, marginal mandibular branch and the cervical branch of facial nerve. So the applied anatomy here is the Bell's palsy. It is a locomotor neuron type of paralysis involving the muscles of facial expression. The compression of the facial nerve in the facial canal near the stylomastoid foramen leads to this. It may be due to viral infection or unknown cause. So the clinical features present on the side of a paralysis are the facial asymmetry, loss of horizontal wrinkles of forehead, inability to close the eye and widening of a palpebral fissure, epiphora, inability of whistling and accumulation of food in the vestibule of mouth, drooping of angle of mouth towards the affected side and drooling of saliva, loss of nasolabial furrow, loss of taste sensation in the anterior two-thirds of the tongue. Next is the lymphatic drainage of the face. So the face is divided into 3 lymphatic territory, upper, middle and the lower lymphatic territory. So the upper lymphatic territory, it includes the greater part of forehead, lateral half of eyelid, parotid area and the adjoining part of the cheek. So all these drains into the preauricular group of lymph nodes. Next, the middle territory, it includes the central part of forehead, medial half of eyelid, external nose, upper lip and lateral part of lower lip, medial part of cheek, greater part of lower jaw. So all these drains into the submandibular group of lymph nodes. Next is the lower lymphatic territory. It includes the central part of lower lip and chin. So the lower lymphatic territory, it drains into the submental group of lymph nodes. So we have reached the end of the session. I have covered the facial artery, facial vein, its tributaries, facial nerve, its extracranial branches. Hope you find this session is useful. See you all in the next session. Thank you.